thanks, Judy, for that introduction, and thank you for inviting me today. So I've been asked to talk to you about the experiences, thank you, that we've had in England, and a little bit about sort of the impact that we've had and some of the evidence around AHP's contribution to public health. So the format that I wanted to use really is to tell you a little bit, very briefly, about the journey that we've been on in England over the last 4 years, what we were setting out to achieve, the progress that we've made against those goals, and what have been the factors that I think have influenced our success, and then where we're going next, because clearly we're not there yet, even though I feel that we've made quite a bit of progress. So does that sound okay and what you were expecting to hear? Yeah. Great. So I came into post in Public Health England right at the end of 2013. So just over 4 years ago. And my role was, I was just given a brief of increase the contribution that AHPs make to public health. And how I did it was totally up to me. So that was a really kind of lovely brief to have, particularly as the professional bodies were very supportive of the role, and who could disagree, really, that AHPs have a huge contribution to make to public health. So we agreed collectively, so collectively means the 12 professional bodies as we were working with at the time, Public Health England and some of the other key national stakeholders like the Council of Deans for Health and the other arm's length bodies like NHS England. So we agreed this ambition that we wanted AHPs to be recognised as an integral part of the public health system. And we felt that that was really important, I think, for the reasons that have been outlined earlier today. You know, the numbers of us, so the amount of contacts that we have with members of the public every week, the fact that we work across all sectors, not just in the NHS, and that we work across all clinical specialities. So because of that, we were conscious that we had the potential and actually do contribute to pretty much every public health priority. But also, as been said earlier, it wasn't just about where we work, it's about how we work. The fact that we do work in a very integrated way. We work across organisational boundaries. We tend to have the relative luxury of a little bit longer time with people than perhaps some of our other clinical colleagues. So we do have that opportunity to develop a rapport. We might see people, over an extended period of time. And a lot of our interventions are already geared towards supporting people to change a behaviour. So we naturally work in that sort of way. So we felt we were very well placed and should be part of the wider public health workforce. So after agreeing that ambition, our early steps were these really. They were about enthusing AHPs that public health should be part of what we do, and in fact already is part of what we do. You know, we were talking about the fact that this isn't necessarily a new piece of work, but equally there's more that we could do. So we were already doing public health, but we just called it good professional practice, really. Then it was about communicating with public health leaders about how AHPs are contributing to their agenda and could do more. Developing more strongly those partnerships that we had with all of the stakeholders. I was very conscious that, picking up on your point, Judith, I think it's been really important that there has been a person employed to lead this, because if it's somebody's job to drive it forward, it will get driven forward. Otherwise, it's kind of, it's the nice thing to do when you've finished your day job. But equally, I work part-time for Public Health England, so one person on their own cannot do this. It needs to be, a collaborative leadership piece, and that's why that development of relationships was so important for us. It was important to constantly raise the profile. And then finally, I think we were conscious, because there are 14 professions for us now, but 12 at the time, working across a range of specialisms. If we all did a bit more around public health, we would make an impact, but would we be able to demonstrate, and would that be visible? So we agreed that what we wanted to do was to focus our combined efforts on a few areas where we might see a more visible improvement. So we chose 4 areas where each of the AHPs felt that they could align themselves to at least a couple of them. So they were making every contact count, the health and well-being of older adults, giving children the best start in life, and emotional health and well-being. And so we set up project boards for each of those, including the range of professions, and tried to drive forward those agendas. And I think what happened was we definitely started to make progress. We were recognised, people were talking about the AHPs more. But one of the things that I was really conscious about, having worked in public health for quite a few years now, was that it rises and falls on the policy agenda. And I was really worried that we kind of got this kind of high level of engagement across the professional bodies and the professions, but that something else might come along and knock it off and we'd be back to where we started. So what we wanted to do was to look at how can we embed what we've been doing into the practice of all AHPs, but also really kind of drive our strategic role in public health and really maintain the momentum. And so it was because of that that we decided that we wanted to develop and publish a strategy for AHPs and public health around developing our capability, capacity and profile further. So this is the work that we published at the end of 2015, and I think this is the work that Judith was referring to in terms of informing the work that Judith just talked about. So in our strategy, we had 5 goals that are similar to what you're working to. So around supporting the current and future workforce to ensure that AHPs have the skills, knowledge and attributes to really drive this public health agenda. Supporting us to be able to demonstrate our impact in terms of measuring and evaluating what we're doing already, but also around stimulating research. Continuing to promote the contribution, so a good communications plan. Supporting us in strategic leadership and strategic connections. So we were conscious that AHPs might be doing loads around public health, but if we're not at the right tables, then it's very difficult to have that kind of strategic influence. So we wanted to make sure that we were connected to be able to kind of inform the progression of the public health agenda, rather than, as Judith alluded to earlier, just being seen as kind of professions that can do making every contact count, important as it is. And then finally, it was empowering us as AHPs to be able to drive forward that service redesign and service change to be able to really deliver this, recognising that our services have probably evolved in a very kind of clinical model. They've developed in a way that we put more emphasis on kind of the very specialist level support for those people with very complex needs, which, whilst that's important, if we were redesigning services or developing services from scratch with an eye to prevention, we probably wouldn't develop them quite that way. And so we need to unravel a bit and rebuild if we're going to really develop this radical upgrade in prevention that we keep talking about. So what I wanted to talk to you now about is go through each of these goals to talk to you about some of the key things that we did and what the impact of that has been. So if we start off with equipping AHPs with the right knowledge and skills, one of the things that I'm very proud of is the work that we've done on the curricula. So back in 2015, Public Health England and the Council of Deans for Health, which, if you don't know, is the body that includes all of the universities that train AHPs and nurses, we did a survey of all of the universities that train AHPs and all of the course leaders to get a sense of what we felt the public health priorities ought to be that were incorporated into the curriculum. So we came up with about 8 principles that we felt were important, and we tested them out with the programme leaders, you know, to see whether do they agree that those are the things that are important, and to what extent are they already included in their courses, and to what extent is public health a priority for them going forward. And what we found from that work was that there was a clear agreement around what we felt were the priorities, that 28% of courses felt that they were already very strong, 52% said that they felt they were not doing too bad, but virtually every course, said that actually they see this as a growing priority and they want to do more and they want some more guidance about what good looks like. So because of that, we developed this curricular guidance, which we published, I think, last September. So this is a piece of work that incorporates or included in its development the regulator, the Health and Care Professionals Council, Public Health England, Health Education England, NHS Improvement, the professional bodies. So that was initially how it started off. And then the more we talked about it, the more we said, actually, this would be so much better if it was UK-wide. So then we invited Wales, Scotland and Northern Ireland, and it became a UK-wide set of guidance that has been endorsed by the Faculty of Public Health and the Royal Society for Public Health. So it's got 12 recommendations, things like public health should be threaded throughout the curricula, that we should use interprofessional learning wherever appropriate. It talks about what are the components that should be included. I won't go through the full kind of detail of what's in there, but I can tweet a link to that if anybody's keen to see it. So the universities are now really embedding that, and we're planning to do another survey with the Council of Deans for Health to see what the progress has been. But we're also conscious about the current workforce. So there's two pieces of work that we've done. So one is All Our Health, which you may have seen. So this is a Public Health England product, but it's probably worth a look because what we were trying to do with this was to put in one place some very easy to access resources about what are the key messages, what are the key things that healthcare professionals can be doing, whether they work with individuals, communities or the wider population. What's the evidence behind those? What's the NICE guidance? And how do you measure your impact? All in one place, because that's what healthcare professionals are saying. We don't have time to go looking everywhere for bits and bobs of information, so it's all there. We want to do more to it. It's still a little bit rusty, I think, in terms of its presentation. But we're getting good feedback and we're going to put more resource and effort into that in this coming year. But the other thing we've developed is AHPs for Public Health, which is a social media community of practice for AHPs with an interest in public health, where we can post new resources, we can have discussions, we can bring AHPs from across the different professions together, and that's grown to about 2,300 members, still growing. I've put a link on your web stream today, so if you're interested in this agenda and you're not a member and you want to be, then please sign up. You can get actively involved or you can just lurk and see what's being posted. But all welcome. In terms of demonstrating impact, there are a few things that we've done here. In 2015, to coincide with the launch of the strategy, we commissioned Sheffield Hallam University to do a piece of work to look at what is the current published evidence around the contribution that AHPs have to public health, and I'll share some of the findings of that with you. But I think one of the key things that came out is that the majority of AHP research is very much individual outcome, clinical outcome focused rather than population outcome. So whilst there's work that clearly would have an impact on population level health, we're not necessarily measuring it in such a way. So there is some evidence, but there's not as much as you would imagine there would be compared to the work that we're doing. One of the things we did as a result of that was team up with CAPA, the Council for AHP Research, to run some joint awards around public health research amongst the AHP. So this is in its 4th year now. It's just out to advert. Any of you doing any research, you might want to consider applying for that. And then the other thing that we published last year with the Royal Society for Public Health is this report, Everyday Interactions, which if you've not seen it might be of interest in the work that you're doing around measuring impact and the workshop that you've got this afternoon. Because AHPs kept saying we want to be able to measure the impact of what we're doing as part of our day-to-day work. So we weren't really here talking about if you're setting up an initiative that has a public health focus, then clearly you'd build evaluation into that. But this is more like the making every contact count type conversations. How do you measure the impact of that? And so I kept trying to do it, and I talked to kind of our knowledge people at PHE, and everybody was saying, oh, this is too complex across all of the priorities and all of the different professions. I'm not quite sure that you can do it. So, but because people kept asking for it, we thought, well, let's try and do something, even if it's not absolutely perfect. Let's do something that will move us in the right direction, because at the moment we're not really even recording what we're doing. And so we did this piece of work that uses a logic model type approach, and I'll talk to you about that in just one sec. So back to that evidence of impact. If these slides will be shared, there's a link there to the report. But I think we've got about 10 areas where there was good evidence. So these are a few of them. So orthoptic-led vision screening for children aged 4 to 5, radiographer-led breast screening clearly is it's one of the national programmes, isn't it? Early intervention by podiatrists on people with peripheral neuropathy in terms of preventing an amputation. Speech and language therapy interventions to improve communication, particularly in young children and in relation to young people who are excluded and potentially could end up in the criminal justice system, as you've mentioned. I think 80% of people in the criminal justice system have some sort of speech, language and communication need, which is, a real health inequality, isn't it? And I'm really pleased that the Department for Education have recently announced a massive piece of work around social mobility that has a really big focus on speech, language and communication needs, which is great. Dietetic interventions for weight management in both children and adults. Occupational therapy, physiotherapy and paramedic interventions in relation to falls. Physio interventions to manage incontinence. In supporting people to engage with, independent, normal lives. Again, physiotherapy in relation to MSK, and there's loads of work now happening on that, isn't there? And speech therapy linked to swallowing post-stroke. So those were the areas where there was a strong evidence base. Clearly, there were many other areas where common sense would tell you that we would have an impact, but we've not got the published research on that yet. Having said that, we're going to repeat this piece of work, or Sheffield Hallam University are, so hopefully there'll be lots more in that regard. This is the Measuring Impact Toolkit. Essentially, it uses a logic model approach, so it focuses on what are we doing, of that what can we record, of that how can we collate it, and of that what is the longer term impact that we're trying to ultimately achieve. And there are logic models for the different public health priorities. So and there's if you first look at it, it looks a bit complicated because we've tried to incorporate something that's relevant to everybody, but the idea is that you pick out the bits that are relevant to you. So because of that, the RSPH have done an e-learning tool to guide you through how to use it. So the next bit was about promoting the contribution that we're doing and raising the profile. And I think it's fair to say that we've had an impact there. So the types of things we've been doing is articles in the professional newsletters, speaking at profession-specific and multi-professional conferences, trying to get AHP topics on some of the public health conferences like the faculty or the local government association conference, blogs, etc. And I think it's fair to say that we have been recognised. So these two reports by the Centre for Workforce Intelligence and the Royal Society for Public Health were looking at who are the wider public health workforce, and they cited allied health professionals as early adopters, recognising that not only did we have the skills and the opportunity, but we also had the enthusiasm for this agenda. So we were one of 5 early adopters of the concept of the wider public health workforce. We won an award for the AHP programme, and same award actually as you won, Lisa, for Nutrition Skills for Life. And we've also managed to get AHP examples into some of the big national documents from Public Health England. So we've got this menu of preventative interventions, which is a document about where is there evidence around return on investment for and what are the types of interventions that the NHS ought to be considering doing. And so there's information about MSK and physio and falls in there. Which brings me on to what we've been doing around strategic connections, which was all about trying to make sure that AHPs are in the right place, at the right table, to be able to influence the direction of public health. So you may not be familiar with this because it's very much an England document led by the Chief AHP Officer in NHS England. But AHPs into Action is kind of our national strategy for the AHPs. And it's a strategy that's, whilst it's aimed at AHPs, it's more aimed at strategic leaders in local health economies. And it talks about what's the transformative potential of AHPs. And if you don't know anything about this, what's really special about it is the fact that it was crowdsourced. So it was developed by 16,000 contributions from AHPs and others and the public about how the AHP workforce could be different and where we could contribute to change. And what I was really pleased about is a quarter of this is about improving the health and well-being of individuals, communities and populations, which is great. So the fact that public health is a core part of that is good. But what we've also tried to do is to ensure that AHPs are on kind of national groups. So the Falls Consensus Statement, was developed and included podiatry, physio, OT, dietetics, orthoptists, paramedics. I think all were part of that. I mentioned the Department for Education report, which is very strongly about speech, language and communication therapists, which is really about them being at the right tables. And so the final one was about leadership and empowering us as AHPs to drive change. And what we were trying to do was to move us out in these concentric circles. So the idea is that the middle part is the prevention work that we do as part of good practice, as part of our roles. The next circle is really the making every contact count and the opportunistic interventions that we might have. And then the third part is more about the prevention as strategic interventions, so services that we are designing based on our expertise and specialisms to develop prevention. So one of the things that we've done in this area, and I'm conscious that this is an area that I really want to focus on more over the next year, but one of the things that we've done is through AHPs for Public Health, the community of practice. And we ran a pilot programme last year, which we called an Advocates programme, which is like a Champions programme, which is where AHPs who wanted to do a service improvement or redesign in their area put themselves forward to be on this virtual programme where we did some webinars with NHS Improvement around service improvement methodologies, and we allocated each of the advocates a mentor. And as a result, we've got 12 really good pieces of work that people have done and delivered in practice. And what I'm really pleased about is that, because all of this was done on a voluntary basis by myself and a couple of colleagues, it wasn't really part of anybody's job as such. I suppose it was probably a bit of my job, but it wasn't their job. But we've managed to get this funded by NHS Improvement as a proper service improvement collaborative for the next year. So we're going to be recruiting another 25 champions. But what I also want to do is to develop some sort of framework, toolkit. I'm not quite sure exactly what form it would be, but that would help middle managers to drive through some of this change. Because I'm conscious what we've got at the moment is kind of enthusiasm at the top in the policy level, enthusiasm on the ground, but when it comes to middle managers, not through kind of fault of their own, but they've got so many other things that they've got to do, that it's really hard for them, I think, to think, well, how do we kind of take time out to decide what's the most important thing that we could do to drive change and then take it forward. So we want to do something that kind of will take you through that process in a logical manner. So in summary, I think it's fair to say that our contribution has been recognised. We've now got to a point where public health leaders see the potential of AHPs. The professional bodies are absolutely supporting this shift. They've been fantastic. They've been with us all the way in terms of implementation plans, and most of the professional bodies are now building public health into their strategic plans and have their own implementation plan. As I've said, the academics are preparing the workforce. There's been a policy shift towards prevention across all of the home nations, hasn't there? And that's starting to translate into kind of commissioning for prevention. And I think probably most importantly, AHPs are changing their practice. So when I first came into post, I used to kind of, if I was talking to an audience of AHPs, just ask for a show of hands about how many people felt that public health and prevention was part of their role. And I'd probably get about 20% of the audience responding positively to that. Whereas the survey that we did last year showed that 87% of AHPs now believe that public health is a core part of their practice. Sorry, exclude the dietitians, but I've obviously nicked this slide from another presentation. 82% see the potential for AHPs to specialise in public health, and 43% would be interested in becoming a public health champion if such a scheme were available. Bear in mind, people who responded to this survey were probably the people who were a little bit more enthusiastic. But even so, I think it shows that there's a progression. So 2 more slides and then I'm done. So things that have influenced our success, I think the partnership that we've had, and this being seen as a collaborative process rather than owned by any one individual or organisation, has been absolutely critical to this, because really it needs to be one of those things that's kind of scattered everywhere. Collaborative leadership and engaging frontline enthusiasts. I mean, what's been brilliant is that, as with anything, you'll get some people who are just fantastic at this and absolutely get it and want to kind of drive it forward in their area, and they're the people that I think we've really needed to have engaged with and have really pushed it forward, because they're the ones who talk about the real life examples of things that have been different as a result of what they've done. It's been really important, I think, to keep this relevant and achievable, recognising that we're working in quite a constrained time, financial constraints, lots of other pressures. I think it was really important not to kind of go and say, well, this is the most important thing you've got to do, you forget everything else. It has had to be quite a pragmatic approach to how people can build this into their work and what's in it for them to do that. Use of social media has really supported that. And it's been important, I think, to connect the work to different people's organisational priorities, so that, again, everybody could see what's in it for them. So in terms of where we're going next, the strategy that we published in 2015 finishes at the end of this year, and so one of the things we want to do is to put all of this into an impact report about exactly what has been the impact, and start to develop a refresh of the strategy. And we're very much hoping that that could be a UK-wide strategy. I think the success of the curricular guidance being UK-wide has been so well received by the professional bodies and the regulator who work on a UK-wide basis. And clearly, whilst our political context is slightly different, what we actually need to do as AHPs is not that different. So I think what we'd ideally like to do, or certainly I've been approached by Scotland to suggest this, that we might have a UK-wide strategy that's topped and tailed with the context that's relevant to the particular country that we're in. But the impact report's going to have case studies, a repeat of that, literature review, as I said. I want to embed this work more into AHPs for Action in England, and do that work on the leadership redesign framework. So that's me. Thank you very much. Thanks.